of the weeks becomes proteinuric. Now we know that she is a patient of preeclampsia. She needs admission. She needs more intense monitoring, profile monitoring, ultrasound monitoring for intra all those. Or the patient by herself is a chronic problem who needs a multidisciplinary care. So these are the two categories where you have to label as high risk. So the risk stratification is going to be an ongoing process that evolves throughout pregnancy. And the risk, as I said, the risk assessment should ideally start at the pre-pregnancy period, then at the booking status, which can be changed as the pregnancy advances to 28 to 30 weeks or 32 weeks or 36 weeks to adjust the plan of care accordingly. So now coming to the second part of my talk, what are the guidelines or the strategies that has evolved globally as well as nationally? Now we'll see the national project. I don't know how many of you are aware of this project, which is our Prime Minister's flagship program. That's a Pradhan Mantri Surakshit Matratva Abhiyan, PMSMA. In fact, I also came to know once I went through the literature. And this is actually a flagship program by our Prime Minister, which was launched in 2016. Initiative of the Ministry of Health and Family Welfare, and it was aimed at providing comprehensive prenatal care based on risk stratification, so as every pregnant woman gets the best possible care. So these are the IECs of this PMSMA. The one point struck me was that every pregnant woman gets one free visit free of cost on the 9th of every month. I thought that would be good for all of us to adopt also, so that at least one free visit she'll get during her entire antenatal period. That will attract her to more of institutional deliveries and all that. And these are the objectives they have put forward. And in 2022, they have gone into an extended PMSMA, which was launched in 2022. And the two added advantages of programs or the key features include extending the care up to 45 days postpartum. We know that some of the complications can originate in the postpartum, a postpartum eclampsia. She can come back with a failure and a cardiomyopathy treated. So a BP can be uncontrolled. So we need to have a follow-up up to 45 days. So that is being implemented. And the second is a financial incentives for both the high-risk patients as well as the ASHA workers, which improves the compliance. So these are some of the guidelines put up by the Ministry of Health and Family Welfare according to this PMSMA. In fact, we are all aware about the FOXI guidelines and the KFO guidelines, but how many of us knows that when if you search the net, we get the Government of India guidelines regarding all the risk factors in pregnancy. This is about hypertension. This is about anemia. And anemia, one point that struck me is the 6 into 6 into 6 strategy. Anemia, the government looks not just into the antenatal women. You can think of all the sixes. A baby which is beyond 6 months, starting of weaning, the baby has to be taken care of to prevent anemia. A school child who resists to eat food at 6 years has to be taken care. An adolescent at 16 years who is after all the junk foods should also be taken care, and then comes a pregnancy at 26 years has to be taken. So 6 into 6 into 6 strategy, if you take care, if you see even a child coming with the first child coming with the mother, you can just see whether that child is anemic or not. This is the guidelines regarding GDM. Okay. Now, this is an international stratification. Modified WHO stratification for cardiac diseases in pregnancy. This is in fact a very informative stratification. I think all of you should have learned about this modified WHO screening or stratification that was produced by the European Society of Cardiology 2018 guidelines. This is a very informative chart. In fact, I love this chart because all the information regarding the cardiac diseases in pregnancy is available from this one chart. I say that every one of you should imbibe this chart because I'm working in a SAT hospital at tertiary center where we get a lot of cardiac patients being referred to us. And when we go through the echo findings, we see that some has got a mild PS, a trivial MR, a mild TR, all sorts of mild and minimal and mild PIH. All this. So we have to immediately stratify the patient into which score she belongs to or which stage, whether it's a class 1, 2, 2 to 3 or 4. So that with that you can know how frequently you have to have her antenatal visit, how frequently the cardiologist should be approached, what could be the maternal cardiac adverse event that is likely to happen if she belongs to class 1. You see only about 2.5 to 5% chance. So you can authentically counsel the bystanders that your wife is going to have an adverse cardiac event to the tune of 2.5 to 5%. Whereas if she belongs to the higher risk category, all this can be changed. These are some of the other cardiac scoring which you all might know, the Carprec scoring 1 and the Carprec 2, which takes into 4 parameters, and the Carprec 2 in fact 10 parameters. This is again the Sahara scoring system for heart disease, congenital heart diseases. Now the other international agency which is very much fond of risk stratifying is the Fetal Mouth Medicine. Just a few minutes. Okay, Fetal Mouth Medicine Foundation, which have made risk assessments in various high-risk conditions like the aneuploidies, the preeclampsia, we know about the preeclampsia prediction and prevention. Now the early GDM, we know about the early GDM prevention and the transgenerational transmission, miscarriage, stillbirth, bacteremia, preterm birth, etc. These are some of the calculators that are already existing charts. We just have to feed in the data in this and the software will calculate this for us. That is regarding the calculator for prediction of preeclampsia, stillbirth. I am not going to details of all this for want of time. This is about how to predict a preterm labor based on cervical length and fibronectin levels, prediction of preterm birth. And now the last concept I would like to convey. This is again known to all of us, but still it's very important, the concept of inverted pyramid of care. It's a shift from the traditional models wherein the emphasis was given to latter half of pregnancy, where the complication sets in and then the management is intensified. But now there's a shift of focus from diagnosis and treatment to prediction and prevention. See, the pyramid gets reversed. Initially, traditionally, it was a pyramid, upright pyramid, where at 12 weeks we just do a basic investigations and proceed to 16, and we have a number of antenatal visits by the time she reaches third trimester. But if you can have a detailed evaluation at 12 weeks, the evaluation includes what is given in the red column: aneuploidy screening, preeclampsia prevention, prediction screenings, SGA prediction, macrosomia, gestation diabetes. A detailed evaluation at 12 weeks means we are going to reduce the number of antenatal visits, at the same time give an appropriate or the best quality care to the patients. So to conclude, risk stratification significantly enhances maternal and perinatal health outcomes through predictive analysis and early interventional strategies. The inverted pyramid care creates more accessible, cost-effective healthcare systems focused on preventive rather than treatment. And the future innovation would be continued advancements in predictive tools and care models will further revolutionize the maternal healthcare delivery worldwide. So these are some of the charts. IECs I took from the net so that you can make it into flex and put it out in your outpatient clinics or your examination halls, rooms, so that the patient will come to know about this and she can assess her red flag signs and her status of pregnancy. So thank you. Here is a highly anxious, high-strung, high-risk woman, now with a smile on her face and a baby in her hands. Thank you for the patient here.
Thank you, ma'am, for that enlightening talk. Moving on to the next session, role of multidisciplinary team in maternal fetal medicine, and we have Dr. Vidya Lakshmi, Clinical Director and Senior Consultant, Department of High-Risk Pregnancy and Perinatology, KIMS Trivandrum. Dr. Vidya Lakshmi is the examiner for Part 3 MRCOG and FNB in maternal fetal medicine. She started the maternal fetal medicine unit at KIMS in 2009 and since then played a pivotal role in the management of numerous complex and high-risk cases. She has special interest in maternal medical disorders and fetal therapy and has authored multiple chapters in publications. Over to you, ma'am.
Good afternoon. We are just pre-lunch, so I don't want to make my session much ahead of we're not having hypoglycemia now. So what does MDT mean? It means we want people to come together. It is not just writing a consultation with the labor ward and walking away and somebody else writes something else. But it's somebody to take the needles or the focus that I own my patient and to take it further so that the outcome changes a lot. So I'll take you through a few cases through which I'll tell you how it can happen. So she's a 27-year-old primary gravida. She was brought to the ER. She doesn't have any comorbidities. She's just unresponsive with slurred speech, right-sided weakness. And the husband noticed a left-sided facial weakness and aphasia. So she comes, we do an MRI. You can see that she has got a hyperintense lesion there, and it's a hyperacute left MCA infarct. So the first dilemma happens, what to do now? Thrombolize, pregnancy being available for contraindication. What does evidence say? It says that intravenous RT-PA can be still considered in pregnancy because the stroke has got a higher morbidity to the woman than the risk of the drug. So it does not cause a placenta, but there's a theoretical risk of abruption and IUFD. So we decided to thrombolize her with altipase, but the weakness progressed. So then we really don't know whether it was bleeding or a progressing infarct. We scanned, re-MRI showed no AC bleed. An MR angiogram was done. There was a large thrombus in the main set of left MCA. So now comes second question, what do you do now? Because you are already given her thrombolysis, can you do a thrombectomy? So this happened in the CT console. I'm seeing Dr. Roshni in the crowd. We did this MDT in the CT console because there was no time to go away from that place. The obstetrician, the maternal fetal medicine specialist, and the family, and the interventional radiologist, everybody joined in the CT console, and we decided that we are going to go with a mechanical thrombectomy. The MDT discussion decided to go with a thrombectomy. The fetal radiation exposure was minimized by reducing the number of angiographic exposures using a low-dose pulse fluoroscopy. You can see the beautiful image that the revascularization happened of the post-thrombectomy in the second half. So we evaluated her for end stroke, nothing major noted other than for monomorphic ventricular tachycardia. She was continued on flecainide and dual antiplatelets like aspirin and clopidogrel. She slowly improved with a close follow-up. At 26 weeks, she had an FGR which is stage 1, and by 35 weeks, she progressed to the umbilical artery, showed an absent and diastolic flow. But with clopidogrel, I had to wait for another week to stabilize to do for cesarean section because that's what the evidence says. So we stopped aspirin and clopidogrel, switched her to unfractionated heparin, monitored her with daily NSTs, and an elective section was done at 36 weeks, delivered a baby of 1.5 kilogram. Post-natally, she was put on antiplatelets and she is now on regular follow-up. So what does it summarize? It says strong suspicion of stroke even in pregnancy. I just heard in the recent RCOG meeting, there's a one take-home message. When you come, any pregnant woman comes to your OP, treat her as a man. Don't think she is pregnant. If you think she is pregnant, you miss the diagnosis most often. Why? Because when pregnancy mimics most of the conditions, you are afraid to take care of so many investigations. So think that it's a man and treat her. So don't delay investigations. Initial emergency management is as per any non-pregnant woman, MDG care, timely imaging, and do the needful because time is brain. Second case is a 31-year-old primary gravida. She came at 11 weeks, everything was fine, but the total count was 79,000 if you have a look at there. And we suggest you a chronic myeloid leukemia in the chronic phase. The marrow was not done, but the FISH BCR showed ABL positive. Dilemma again. Are we going to do an MT because she's just 12 weeks or continue with the CML? So again, the family or the woman has the right to choose. Every risk was explained because the risk of blast crisis was really a concern for us, because she may go in for a transplant reason there. Adequate control over the disease to avoid progression versus minimizing the exposure of fetus was discussed. The family wanted to continue pregnancy whatsoever. She was started on aspirin and low molecular heparin because she has a very high risk of thrombus. The total count remains stable for all our good. At 30 weeks, the total count again started to increase to 75,000. So again, we are confused. Are we going to do a poorly controlled CML with leukostasis? Because it would lead to maternal worsening and placental insufficiency, whether to deliver her now. Again, MMDT team, close monitoring decided, if the count goes above 100, then we decided to do leukoreduction and interferon and terminate pregnancy with a maternal benefit. And with close monitoring, we continued, and by 33 weeks she went to stage 1 FGR, and we pushed her to 36, and she delivered a healthy baby, and then chemotherapy was started, imatinib 400 and hydroxyurea. We had to suppress lactation because we can't give biologics when she was lactating and she is on regular follow-up. So CML in pregnancy, we are worried about disease phase, disease burden and timing of delivery. Pregnancy doesn't alter the course of CML, but if she goes into blast crisis or chronic phase of high-risk features, MTP is the gold standard. Wait and watch can be reasonable if the woman is in chronic phase. and patients who are showing very high rapid cell increasing cells, we can think about the treatment options. TK, the targeted thyroxine kinase inhibitors have revolutionized with the extended life expectancy. But however, if she presents in the first trimester, TK should be avoided. The persistently raised WBC count can cause glucostasis and placental insufficiency and even IUFD. So CML, MDT again, low dose aspirin, clear for monitoring. If she goes into blast crisis, you're worried. Glucophoresis if it's more than 100 into 10/9. And ETMF alpha is safe in pregnancy, individualize the timing of delivery, and treatment immediate postpartum with biologics, avoid breastfeeding is the treatment. The third case was a real trouble for me where I involved even Dr. Suresh called him because she was a 51-year-old. She was a gravid of 5 with no live issues. First was a spontaneous conception, second was an FGR, IUFD, APLA was positive, third, fourth was IVF with miscarriages, fifth is an IVF with a donor, but she has got 2 embryos transferred and she's with a triplet pregnancy, the surprise is FTS. And then we spoke to her about VAMA. What is VAMA? It's very advanced maternal age, obstetric APS, triplet pregnancy and with 1 monochorionic pair. So she had everything under sun. So we spoke to her about the option of fetal reduction. It's always wise to reduce the monochorionic pair because you don't want the complications of monochorionic, and especially when she's 51 with her obstetric APS. We always prefer a singleton over a twin pregnancy. So we told her about reduction of the monochorionic pair. But that was not the follow-up. Considering the age, maybe it was last chance for pregnancy, we discussed whether to terminate monos, whether to terminate whatever it is. So finally we decided to terminate reduction of the monochorionic pair. For our surprise, she developed cough, UTI, flu, and she couldn't take the procedure. So she went home, comes back at 16 weeks to do a screening for a monochorionic pair. Screening shows some surprise. The singleton fetus shows 2 markers. So what do you do next? Because you're going to reduce the monochorionic pair. If the singleton is unemployed, then what do I do? So again, the whole MDT started again. The fetus B was normally grown, fetus C was small. So again, there is a monochorionic issue started already. She's 60 weeks. So we discussed whether to do amnio for 3 fetuses because are we going to do multiple punctures? Finally, the decision was very difficult for everyone. And after 2 weeks, they came back and they said we'll do amnio for the fetus A, who is the singleton, and then B and C, single prick because you assume that monochorionics have a common karyotype. Still you can have heterokaryotypia, but I didn't want to do 3 pricks there. So finally, we did an amniocentesis for the singleton sac and for the monosacs, and the results came back as normal, and we did a reduction of the fetus A, which is very rare because that kidney was showing echogenicity. So we really don't know what is going to happen, and we continued the mono pair with all pregnancy continued, but she went uneven for 36 weeks, and she even comes back with the 2 darling girls to us, and both are well. Case 4, she's a primary good case. She's an SLE known case, active disease, why I put active with a secondary APS. She had an avascular necrosis of the hip already, and she was on aspirin, Clexane, HCQ, azathioprine, and Micellar. And to our surprise, at 28 weeks, she kicks into category C COVID. So then again, the whole thing started because she was the one who is likely to go into severe respiratory problems because of the immunosuppressants. We kept the ECMO ready for her, but she escaped ECMO, but came out of the COVID. And then if you look at that, everything went well, but at 28 weeks, she had a stage 1 FGR, and 34 weeks, the Doppler became abnormal. Emergency LSES was done at 36 weeks because she had an avascular necrosis. We can't put her leg up, so a planned cesarean section, and she had an APH. The postpartum period was uneventful, and she went home with all the drugs, and after about 3-4 months, I hear from Dr. Rafika that she died with multi-organ dysfunction in the ICU. So we say cheers to ourselves, we did everything very well, and the family, then we lose follow-up after 6 weeks, and then she died after 3 to 6 months postpartum. So active SLE is a contraindication to have pregnancy. So SLE is the only disease where you encourage pregnancy when the disease is inactive for at least 6 months prior to conception, and the risk is very high if she has a lupus nephritis, hypertension, Raynaud's phenomenon, refractory disease. These are all the big emphatic no for conception. The fifth case, she is 32, previous pregnancy with 32 weeks gestational hypertension. It was a surprise that she had just fever myalgia. Everyone thought it was flu. The platelet was 57,000. So worked up, and then it was a refractory thrombocytopenia. She was not responding to anything under sun. Treated with IV methylprednisolone, IM for 5 days, followed by Visalon oral. She was put on SCQ. Nothing helped. And at 27 weeks, she started to throw, gestational hypertension was given to labetalol. 27 weeks, the platelet counts are still at 50,000. Then IV ended, and then 27 weeks, 2 days, she comes to the labor ward with headache. And the blood pressure of 150, 102 plus urine albumin. Magnesium sulfate was started. We started her on 2 SDP and on RDP. The platelets improved to 60,000. So they immediately decided to go ahead because she already has gone into preeclampsia and seen the symptoms. Platelets are very low because we can't keep the platelets up in such cases because it's refractory thrombocytopenia. Step up the platelets with SDP, RDP, whatever you can, and then deliver her. Because she was close to 28 weeks, Naveen said, go ahead. So we really didn't have any confusion there. We delivered, and it's a preterm live baby of 895 grams. She's doing extremely well. So post LSCS also, the platelets didn't help. So we had to start her again on the IVIG course, 5 doses, azacitidine, Visalon. In view of this, we decided to switch her to MMF. Mycophenolate mofetil, we also know that we can't give her breast milk, feed the baby. So again, we discussed with the family. They agreed with suppression of lactation. So slowly with MMF, Visalon, SCQ, lactation suppression, she improved and she went home well. So hematological involvement is one of the most deadliest complications of SLE, and thrombocytopenia is a very risk thing. And poor prognostic factor of SLE is thrombocytopenia. The first line agent is corticosteroid, second line is SCQ and azacitidine. Splenectomy may be needed in pregnancy, but it is a resort measure only. The sixth one, who is close to 38 weeks, non-booked case, she comes to the ER with the pulse rate of 160, blood pressure of 130/90 with a good SACH, and multiple skin lesions bilaterally on the lower lip. Past history, just for the tuberculosis, there's nothing which we got. And you see the ECG which is showing a narrow complex tachycardia, AV-NRT, and the baseline echo showed a dilated RA, moderate TRM, mild right ventricular enlargement. And she was anemic, but with the refractory tachycardia, the decision was made to do a reverse because in pregnancy, cardioversion is not contraindicated if that is needed. So the medical cardioversion is the first line of management. We reverted her with adenosine 3 mg first in the ER. Post reversion, the cardiac heart rate came to 122, and then we switched her to Metla, and the basic tests were negative. So the decision of an emergency LSCS was made, and she was having a healthy male baby. And post LSCS, she needed verapamil because she will again go for reentrant tachycardia. So post LSCS, she was started on verapamil, and she went home safe. Arrhythmias are most common cardiac complications in pregnancy, manifesting either during pregnancy or first time as an exacerbation in those with pre-existing arrhythmias. Supraventricular tachycardia is the tachyarrhythmia characterized by heart rate above 120 beats per minute. Palpitations occur frequently in pregnancy. That is why I told you treat her as a man. And cardiac evaluation should be done. Actually, in KIMS now we are pushing to have every woman going through a cardiac evaluation. After 35 years, definitely it is mandatory to have a cardiac evaluation. In high-risk women, definitely yes, like a family history of unexplained sudden cardiac arrest, young strokes in the family, anybody who has a history of transient ischemic attacks, all those women should be subjected for an early screening cardiac evaluation, which Dr. Sujamal already mentioned. Risk stratification helps a lot us to manage them. So, if I have time, I have 15 seconds. So, she is referred at 32 weeks IUFD. The only catch was a discrepancy in the pulse, so she was diagnosed to have a Takayasu. So, Takayasu is she was in stage 5 active disease, so she can't fall pregnant. So stabilized her, she was given MMF, tacrolimus, stop tac, and she became pregnant. So I won't go beyond this time. So the only thing which I want to tell is this last slide. Every mother and baby deserve the strength to be a team behind them. Early referral and regular FDG care is vital. There is no wrong time to make the right decision. Even in the CT console, even in the corridor, even in the, wherever you want, you can make the right decision. Together we make the high-risk pregnancy safer. A coordinated team makes all the difference. Compassionate teamwork transforms challenges to healthy success stories. Thank you all for the patient listening.
Thank you, ma'am, for that wonderful session. You carefully selected and discussed highly morbid medical conditions that truly enhanced our understanding and importance of multidisciplinary care. We come to the last talk of the morning session, obesity in pregnancy, optimizing outcomes for mother and baby. And we have the speaker, Dr. Sangeeta Meno, Professor and Head of the Department of Obstetrics and Gynecology, Government Medical College, Alapura. With a distinguished career spanning over 26 years in medical education, her driving passion lies in reducing CS rate and maternal mortality, reflecting her deep commitment to safe motherhood. She serves as an assessor for the confidential inquiry into MD and MSR and trainer in the ORR team. I'll welcome her on to stage.
Thank you so much. Thank you, Vidya, and the team at KIMS for having me here today. And also very appropriately and, very aptly choosing this for me. It has succeeded in scaring me as well. Obesity in pregnancy, and really not something that we are too far away from, because there's a lot of it. For the people who are actually waiting to have their lunch, just listen to the first two slides. Obesity creates problems through all trimesters and through postpartum. So whenever I tell postgraduates, if you're asked in your exams, what really is the risk factor for this particular disease, you can just throw the ball in the dark. You will be right if you say obesity, both for obstetrics as well as for gynecology. And there is no point telling this huge woman to lose weight in pregnancy. It should be a pre-pregnancy situation, and therefore these women must come for pre-pregnancy care. And they need specialized care. They need a lot of infrastructural changes as well, as I'll let you know. And as Vidya had told us, a multidisciplinary team for these is extremely important. And obesity definitely interferes with varied aspects of care. Interpretation of results, the clarity that you would get with an ultrasound, and even the dosage of very many of our medications, including antibiotics. So you need to know, it's not blanket 500 milligram Ethali, you need to know mg per kg. And pregnant obese women, they tend to, more often than not, actually labor dysfunctionally. They don't really go through the kind of smooth labors that other women do. So it pays for us to be very much prepared, well in advance for these women. Be it siting cannulas, simple IV cannula is difficult for them, so it's better to site two and do it early, because you don't want to rush at the very end. Even putting in an epidural, if she's willing, or if she runs a very high risk of having a cesarean section, it should be done very early, because for them general anesthesia as well as regional anesthesia is difficult. And they are prone, as Uma had already told you, depression and anxiety, and so these women need to be seen by a psychologist or a psychiatrist. This is just for you to understand that the kind of obesity values that you see in the West are not applicable to India. And when we say BMI, you must think that it really doesn't take the general frame of the patient. It doesn't take into account how much of lean body mass she has and what is her fat distribution. Why is that so important? Because in India and Southeast Asia, we tend to accumulate fat along our abdomen, which is a big cardiac risk factor. And for us, obesity is greater than 25 and not greater than 30 and 40 as the West has. And remember, obesity is a state of chronic inflammation. So it is this inflammation that leads on to insulin resistance, and this is exactly what will be the cause for most of our problems, including preeclampsia and everything else. And you can talk about the West, but in India, as per NHFS 5 of 2021, 24% of our population is obese. So we jolly well do something about it. So I'll just run through what happens pre and early pregnancy. There is definitely subfertility and infertility. Many of them could be anovular. The inflammation can account for a lot of decreased endometrial receptivity. They could have anovulation, delayed conceptions. They're prone not only to first trimester abortions, but to recurrent pregnancy loss as well. They have poorer outcomes with ART. They need more gonadotropins. They have more cycle cancellation, and their oocytes would probably be of a lesser quality. And very sadly, they have more congenital abnormalities. Again, inflammation. So there is a strong association, remember, a strong association between obesity and cardiac defects, and definitely a moderate evidence to say that they are linked to neural tube defects. But just sadly, the diagnosis for all these may be suboptimal because the window that you get through a very obese abdomen is not very good. So you may tend to miss some anomalies in these women. They must know that as well. And in the first trimester, when we use the screen, if you can't get a proper NT, please use the transvaginal probe because you may not get it through a transabdominal. And if you're planning to do for whatever reason, not just because of obesity, but because she has some other risk, if you're planning an NIPT, remember the fetal cell fraction that you're likely to get for an obese woman is much, much less. And therefore, you can have an inconclusive report. And when you start low-dose aspirin, obesity per se is not an indication. It is a moderate risk factor, but when it's combined with any other small risk factor, definitely you need to start low-dose aspirin. The sad thing is stillbirths, forget anomalies, stillbirths as well increase almost twice the number, and when there is the BMI morbidly obese, when the BMI is more than 50, maternal mortality and morbidity is extremely high. So when you counsel these women, all this must be told to them. Medical comorbidities, 3 times more GTM, and I would strongly recommend, though there are no actual guidelines that the spot GTT functions as well as the ADA criteria, but in these kind of women, it probably would be good to get a fasting value, then give 75 grams and do the 1 hour and 2 hour as per the IADPSC ADA criteria. And they need a very, very stringent watch on hypertension. I come to, and remember, small things will get missed. Like for example, many units may not have a cuff size that will fit her. So you will take it with a smaller cuff and you will get higher readings. So you must have a large size cuff in all your OPs and in the labor rooms. You have more depression and anxiety. They don't move around much. They're largely at home, and therefore they tend to be a little depressed, and you need to address that as well. Twice the incidence of sepsis in these kind of women, and we all know that obese women are prone to develop venous thromboembolism, but remember the score is 2 when her BMI is more than 40, and they definitely need postpartum thromboprophylaxis. And when she's more than 30, the score is 1. When it is combined with any 2 other factors, she may need antenatal thromboprophylaxis as well. And when you're giving the heparin, remember it's not the 0.4 ml subcutaneously that you usually write offhand. Remember, the standard dose is 0.4 when she's between 50 and 90. But if she's over 90 kgs, you may need the intermediate dose, which is either 0.4 ml or 40 mg BP or 60 mg OP. And if she is 160 to 130, even 80, that is 0.8 ml once a day if she's more than 130 kg. If she's really more than 130, then you need to go per kg body weight, and it's 1 mg per kg body weight. So all these things, whether it is, I just put an example as heparin, but even antibiotics, you will need to change the dosage schedule. And these women, their growth velocities, as all other women, need to be plotted. They can have large babies, but they can have small babies as well. So both ends of the spectrum are active for these women. So you need to look at their growth, and it is difficult to do scans for them. So you must be careful there. And these women, especially if you're having them, there is actually a government order in Kerala that says that if you have women more than 100 kilos, she must deliver in tertiary care. The West doesn't really feel so, but they must be seen by a cardiologist. There is no point looking at fasting lipid profiles in pregnancy because you really don't treat with lipid-lowering agents, but they must be seen by a cardiologist and must have an echocardiogram as well. And very importantly, since they're very prone to have cesarean sections, they must be seen by an anesthetist, preferably somewhere close to 30-32 weeks. PAC is a must. And the Institute of Medicine actually talks about weight gain standards, which is an extremely difficult thing to implement because you can't tell them to have 0.2 kg increase in weight per week. All that is, I don't know, I feel very impossible to achieve. But this is what is recommended when they're obese and more than 30 is their BMI. The amount of weight they increase is just 0.2 kg per week. Not only is the antenatal period difficult, the intrapartum period is also extremely controversial. Preterm labor, nobody really knows whether it is more or less, but you could imagine with the kind of inflammation that persists that it is quite likely. There is definitely an increase in the inductions of labor, the augmentation, the failure to progress, and sometimes they don't push and the instrumental deliveries. Cesarean section risk doubles. For PPH is also 1.3 times what you would expect in the general population, and shoulder dystocia that we all know these kinds. So when you're using an instrument in an obese woman, think you could deal with shoulder dystocia, put that instrument in the theatre because you'll have more help. Do we really need to induce all these women? Can we allow them to go into spontaneous labor? Or should we do elective cesareans for them? Everything is a nightmare for her. So it should be a team decision that you take along with the patient. But there are a lot of studies that tell you that you could induce at 38 to 39 weeks to actually prevent shoulder dystocia and also to prevent the horrific appearance of what is an unexplained stillbirth in these women. Breastfeeding, failing lactation, lactogenesis per se is less in them, and latching with a large breast, sitting up, all these are issues, and therefore breastfeeding is also a problem. Anesthetist is always worried when we do cesareans, but we don't really see the very obese. We see 120, 130, but not the 150, 180 kgs. But failed tracheal intubation is quite high. The airway obstruction in these women, the tongue falling back is also common. So that's why now most anesthetists, when we write budgets for what we need, video laryngoscope. So the video laryngoscope, the gum elastic bougies, or the laryngeal mask airway could be life-saving for these women. You need longer epidural needles and they are available. And all in all, the anesthetist must know when this woman is either admitted or when she's in the labor, because a senior person must tackle her. The technique of cesarean section is really, what would I say, is largely individualized, because whether you have a huge panniculus, the abdomen is overhanging. So are you going to use a vertical incision above the panniculus? Are you going to lift that panniculus like we all do and wipe underneath where there's likely to be fungal infection? And are you going to make an incision there? This has been thrashed around quite a lot, and it says the vertical incision may actually not give you access to the lower uterine segment. So it's better to go below the panniculus and make the transverse incision. But these women have large amounts of subcutaneous tissue. You do need to close the subcutaneous fat, but whether to put a drain in the subcutaneous tissue or not is controversial. So after they deliver, they need to be seen in specialized clinics. So you tell them they must lose weight because they need to be there for the baby. They must engage in actual and very active childcraft. So they must lose weight. An active program with a lot of support. It's very easy to tell somebody, listen, you need to lose weight. But give them incentives. Be one with them. They probably will. So they need support and encouragement. And they need, in the postpartum period, definitely monitoring of their metabolic parameters. Their cholesterol, their blood pressures, their sugars, everything needs to be looked at. And how do the babies do? Not so good as well. They are big at birth, more than the 95th centile. They tend to get obese as young adults, and they also run almost 25% chance of having diabetes and hypertension as young adults. This slide, I think, is extremely important because we really do not realize the kind of equipment we need. A large size BP cuff is a small thing, which is very easily affordable and easily gettable. Larger size stockings, theatre gowns. When they come into the OP, I remember a time maybe about 20 years ago, which happened in Trivandrum in a large hospital. One very obese lawyer came in, sat on one of the chairs, it broke, and she had a fracture of her spine in pregnancy, and she sued the hospital to Kingdom Come. And the reason was there was no specialized chair for the obese woman to sit in. So all these are things that you need to think of. So without armrests, they can kind of space themselves out. We now realize, we all buy, especially in the government, we buy wheelchairs and theatre tables as L1. That is the one that is the cheapest, because we can't afford the very good ones. But you must know the weight limit on each of them. The good tables are all, OT tables are all 150 kgs, 175 kgs, are all 110, 120 kgs. So you have somebody more than that. It's not so much as the weight, but the size. If you've looked at sizes, width of these tables, they kind of overhang on the sides. Shifting trolleys, they actually look at the hoisting system, that is a pulley kind of a thing to shift them out, or lateral lifts. And sitting weighing scales, because they really can't, your weighing scale, some of them may be above 200 as well. So it's a good thing to do a dry run in the third trimester and see whether she actually fits into many of these apparatuses that you use. Even the toilets and the washrooms that you have must be easily accessible for her. And everybody in the labor room should know where this equipment for this woman is stored. So they have a lot of pre-pregnancy problems which you need to sort out. They lose weight. If she's not responding to the regular medication, you could ask for weight loss medications, refer her to a physician. Bariatric surgery is a possibility for these. And remember, they don't get out much. They're likely to be vitamin D deficient. You need to supplement them as well. And after bariatric surgery, you want her to lose weight, because once they lose weight, they take pregnancies much better. And the nutritional problems start occurring. So wait for about 12 to 18 months before delivery. So this is things you need to look for. Anti-obesity drugs cannot be given in pregnancy. Pre-pregnancy, yes, they lose weight and then they get pregnant. And this is my last slide. I'm kind of sighing because I was worried about the time. But effects of weight loss, there's definitely positive associations, less preeclampsia, less GDM, less stillbirths and less anomalies, which is a big thing, less shoulder dystocia, metabolic profile alters, and cardiac event mitigation has a large role to play when they lose weight. So let's be prepared. As a first step, I think we need to get that BP cuff. If you just look at it, just go back and check, very many of us will not have that extra large BP cuff. Thank you so much.
Thank you, ma'am, for that wonderful session. We'll now break for the lunch. To ensure smooth service, we have arranged 3 counters for easy access. As we are running slightly behind schedule, I request all delegates and faculty to reassemble in the hall by sharp 2:10. That leaves us 30 minutes for the lunch break. And I also request all of you to take a few moments to visit the various stalls arranged at the back end of the hall.